This hearing is called to order. On December 30th, 2019, Dr. Li Wenyang, a 34-year-old ophthalmologist at Wuhan Central Hospital, took to a group chat he was in with some friends from medical school to discuss a SARS-like illness that had recently been sickening people around the city. He posted a snippet of a lab analysis that had found SARS coronavirus and extensive bacteria colonies in a patient's airways, and said this new illness had even led his hospital to quarantine some patients in the emergency department. "So frightening," a member of the group chat replied. "Is SARS coming again?" Suffice to say, the Chinese Communist government, which, like all authoritarian regimes, is often more concerned about protecting its image than the life and safety of its citizens, was not pleased. And even as dedicated public health experts scrambled to warn each other and to collect more information on what was happening, China's security services were busy trying to stop them. In probably the starkest example, on January 1st, the Wuhan Public Security Bureau summoned 8 doctors, including Dr. Wenyang, for posting and spreading, quote, rumors about Wuhan's hospitals receiving SARS-like cases. While Dr. Wenyang was eventually released 2 days later, that wasn't before he was forced by police to sign statements acknowledging that his warnings had been, quote, illegal behavior. Meanwhile, even as the city of Wuhan and the nation of China were getting sicker and sicker, business as usual didn't stop. Community events, political parades, public gatherings, and global commerce, including most importantly for this hearing on global aviation, continued, allowing this virus to spread first within the city of Wuhan, then within the rest of China, and finally out to the rest of the world. At 2:58 a.m. on February 7th in the city of Wuhan, Dr. Wenyang died from the very virus he had tried to warn about. A virus which, as of today, has infected almost 95,000 men, women, and children across the globe, including right here in the United States, and has killed more than 3,200 people, including 9 who are in Senator Cantwell's home state of Washington. What we now know is that the virus Dr. Wenyang and others were warning about, and the virus that took his life, wasn't SARS, but it was similar. It's the novel coronavirus, now known as COVID-19. The spread of this virus across the globe has had and continues to have tremendous and far-reaching impacts. Commerce has slowed, faith in government has been shaken, and people are, understandably, scared. This virus has also called into real question the efficacy of international organizations like the World Health Organization and the ICAO, both of which we reached out to participate in this hearing, but both of which either declined to participate or didn't respond. The ICAO, the International Civil Aviation Organization, for instance, excluded Taiwan from its information sharing regarding the virus. This despite the fact that viruses like this, as SARS showed us, spread overwhelmingly by air travel, and Taiwan has the 11th busiest airport in the world. The WHO, for its part, has praised at every turn the response of the Chinese Communist government, despite the mountain of evidence showing that they played down the seriousness of the virus and the extent of the spread for more than a month. If these organizations aren't going to look out for the broader global interests and are going to instead praise authoritarian regimes, it begs the question if it's time to reevaluate our participation in them, or at the very least to make a concerted effort to push reforms. COVID-19 is a real and serious challenge, and we need cool heads and fact-based decisions. Not panic, not hysteria. Unfortunately, some in the media, whether intentionally or not, seem to be inciting panic in Americans over the virus. That's a large part of the reason why we convene these hearings, to give the American public the opportunity to hear straight from officials on the front lines without spin or partisan bias. So here's what we know. This is a rapidly changing situation. Every day, and on some days every hour, we're learning more about the virus, where it is spread, and how the human body responds. So far, the mortality rate has been around 3%, and most of the deaths have been in the elderly and those with underlying health conditions. The virus appears more transmissible than a typical seasonal flu, but so far reports indicate the vast majority of cases are moderate to mild, requiring little to no medical attention. Early on, the administration acted swiftly to limit travel to and from the affected regions and to quarantine Americans that had been to those regions and to deny entry to foreign nationals from those regions. This was the right thing to do, and those actions have proven critical for slowing the spread of the virus to the United States, and it's bought us additional time to prepare. But now the virus is here, and it's spreading, and we must be ready for the fight ahead. There is more that can be done. There is more than should be done. Communication between agencies and municipalities is vital to containing the spread of the virus. In San Antonio, communication was lacking, and a patient was released from Lackland Air Force Base prior to testing positive. After testing positive, the patient was returned to quarantine and is currently under the supervision of the CDC. I urge the CDC to stay vigilant in keeping lines of communications open with all localities to ensure the safety of the public health in Texas and all across the United States. We must do everything we can to marshal every resource necessary to protect the safety and lives of Americans. So I look forward to hearing about the facts. I look forward to hearing about the medical science. I look forward to hearing about what we know, what we're doing, and what more we can and should be doing. And with that, I recognize Senator Sinema for her opening.
Thank you, Chairman Cruz, and thank you to our witnesses who are here today for your efforts to protect Americans from infectious diseases like the coronavirus. While they're not testifying today, I'd also like to acknowledge the efforts of our U.S. air carriers and the transportation industry. In the face of a public health crisis, we must work together to share the burden of keeping Americans safe, both here and abroad, from a potential global pandemic. Today's hearing will focus on the current systems in place to collect contact data from travelers entering into the United States and to close gaps where they may exist. We need a timely and orderly way for travelers to input detailed contact information based on criteria the CDC has outlined. I spoke with Vice President Pence yesterday about an opportunity to quickly develop and implement a method to collect this information, and I sent him a follow-up letter this morning. Our public health officials need to ensure that we have a direct link to travelers and to eliminate gaps that allow travelers to enter the United States without public health officials being able to reach them in the case of potential risk or exposure. I represent Arizona. We have confirmed coronavirus cases. It's critical that Congress pass a bicameral and bipartisan supplemental package that devotes necessary resources to developing vaccines and treatments, that reimburses states and local governments, and that ensures the safety of our frontline workers, our seniors, and other vulnerable populations who are most at risk. Although we do not yet know the long-term impacts of coronavirus, the impact we've seen thus far calls for action now to protect and to reassure the public. As the situation continues to evolve, the government must continue to work together. We must coordinate with states and communicate with our industry partners. I look forward to hearing today's testimonies, and Mr. Chairman, I yield back.
Thank you, Senator Sinema. Now recognize Senator Cantwell, the ranking member of the full committee.
Thank you, Mr. Chairman, and thank you and Ranking Member Sinema for holding what I consider to be one of the most important subcommittee hearings we could possibly ever have. I want to take a moment and send my deepest sympathies to the people of Washington State, the families who've lost loved ones, and to the healthcare workers who are continuing to work diligently to respond to this epidemic. We are working hard in the state of Washington, but even the numbers, Mr. Chairman, continue to increase. We now have 10 people who have died from the coronavirus, and we now have 39 confirmed cases. 231 people are being monitored by public health officials, and we've had schools and businesses and even a federal facility that have been shut down temporarily as more people have been detected as possibly being exposed to the coronavirus. All the while, people are experiencing symptoms and yet not getting tested. This is the main focus I believe we need to communicate today, that we need to have a robust testing regime, all academic and commercial facilities across the United States participating in a testing process. This will give us better information, and it will get us more information about the spread, the community spread of this disease. Until last Friday, those suspected of COVID-19 in my state were required to have their tests sent to the CDC to obtain results. And now, since the FDA's actions on last Saturday, we will be able to run more aggressive tests. But I still think we're only at a few hundred tests per day in the state of Washington. We need to be in the thousands, if not more. So I hope that we will get this right for the future of other states who are going to deal with this dilemma and figure out how to have a clarion call to all labs to please develop these test kits in compliance, but get the kits developed and do the testing, because people are calling with what they think are symptoms and they want to be able to be tested. I think that today's hearing, too, is a perfect example of why that's so important. We now have 14 states that have confirmed cases, and one of the persons is a person from North Carolina who tested positive after visiting the nursing home in Washington State that has been the subject of so much attention, and then traveled home to North Carolina on a plane. This underscores the importance of making sure the aviation sector is also prepared in how we mitigate the impacts of virus spread. After all, there are more than 44,000 flights in this country every day, and more than 2.7 million people fly in and out of our U.S. airports. We have just sent a letter to the major airlines and airports asking them for their plans to meet this challenge. Further guidance, I think, hopefully we'll hear today on how we can keep the flying public safe. The airports and the airlines, in a spirit of cooperation, need to understand measures that can be taken to help us in dealing with the coronavirus, and they should not be left wondering from the federal government what they should be doing. We should be very clear about what measures we can take or what measures we should take to help keep the flying public safe. So I hope the Department of Transportation and the CDC will shed some light on that here today in this hearing. I look forward to hearing more about their answers, and Mr. Chairman and Ranking Member coordinating with you how we can get this information out to the public in a timely fashion. The public wants to do everything they can do too, but we have to get crisper on our answers about what we should be doing today. Thank you.
Thank you, Senator Cantwell, and please know that the people of America across the country are lifting up, in particular, Washington State and the families who are grieving the loss of their loved ones. And I hope we will continue to see bipartisan cooperation to marshal all the resources that are necessary to combat this virus and to do everything possible to prevent any more loss of life. With that, let me introduce the witnesses we have today. Mr. Joel Sabat is the Acting Undersecretary for Policy at the Department of Transportation. Mr. Sabat has served extensively across the Department of Transportation since the early 2000s. In 2005, he oversaw the U.S. government's reconstruction of Iraqi airports, ports, and railroads, and served as the transportation counselor to the U.S. Embassy in Baghdad. He also previously served as Deputy Assistant Secretary for Transportation Policy and Deputy Assistant Secretary for Management and Budget at DOT. From 2012 to 2018, Mr. Sabat served as the Executive Director of the Maritime Administration. Most recently, in January, Mr. Sabat was named to represent the Department of Transportation in the President's Coronavirus Task Force to help coordinate strategy to prevent the spread of the outbreak. He graduated from Georgetown University and Harvard Business School. Rear Admiral Stephen Redd is the Deputy Director for Public Health Science and Implementation Science at the Center for Disease Control and Prevention. In this capacity, Dr. Redd is responsible for state and local readiness, emergency operations, select agents and toxins, and the nation's cache of emergency medical countermeasures. Prior to this role, Dr. Redd was the director of the Influenza Coordination Unit. He was also the incident commander for the 2009 H1N1 pandemic response. Dr. Redd received his bachelor's degree in history from my alma mater, Princeton University, and his medical degree with honors at the Emory University School of Medicine. He trained in medicine at Johns Hopkins Hospital and completed the 2-year Epidemic Intelligence Service training program at the CDC. And our third witness is Mr. William Bill Ferrara, who is the Executive Assistant Commissioner for Operations Support at U.S. Customs and Border Protection. Mr. Ferrara has served in numerous roles at CBP. Previously, Mr. Ferrara served as the Acting Executive Director of Mission Support in the Office of Field Operations, where he was responsible for managing an operating budget of $4.1 billion, as well as providing asset and logistical support and customer-focused human resource solutions for nearly 28,000 employees. From June 2016 to June 2019, Mr. Ferrara also served as the Director of Field Operations for the Boston Field Office. From November 18 to February 19th, he also performed the duties of the Department of Homeland Security Attaché to the United Kingdom. He holds an Associate of Arts degree in Business from the Community College of Rhode Island and is a graduate of the CBP Leadership Institute and the University of Chicago Booth School of Business. We'll now recognize Mr. Sabat for his testimony.
Good afternoon, Chairman Cruz, Ranking Member Sinema, and distinguished members of the subcommittee. Thank you for inviting me to testify on behalf of the United States Department of Transportation and Secretary Elaine L. Chao on our efforts to minimize the risk of the spread of COVID-19 in the United States. On February 26th, President Trump appointed Vice President Pence to lead the U.S. government's effort to combat the virus. Secretary Azar chairs the White House task force, and I have represented the Department of Transportation on the task force since its inception on January 31st. The government's health professionals have the lead in determining the response to the coronavirus. DOT, in its supporting role, has and will continue to coordinate daily with aviation stakeholders, foreign counterparts, and other federal agencies to manage the risk in the United States. In this capacity, the Department of Transportation continues to ensure, first, an active air bridge remains in place for the safe return from affected areas for Americans, in addition to the thousands who have already safely traveled home from overseas. Secondly, airlines funneling passenger flights to one of 11 designated airports equipped to health screen Americans returning from the virus-stricken areas. Third, continued air and sea cargo traffic between the United States and China and other countries, such as South Korea and Italy, as the virus spreads. Fourth, health protocols established to protect the crews of aircraft continuing to fly between the United States and foreign locations. And finally, dissemination of health messages about the virus for airlines to use to inform their passengers. Our travel restrictions have been a remarkably effective first layer of health screening of overseas travelers before they return home. These travel requirements delayed the spread of the virus from China to the United States, giving the nation precious time to prepare further measures and plan for proper mitigation. In the first 25 days since the President's proclamation, only 15 cases were detected within the United States. Our actions ensured that nearly 200,000 Americans who were in or had recently left China could return to the United States through an air bridge home. The number of passengers traveling from China to the United States has fallen from roughly 15,000 people each day before the virus outbreak to fewer than 1,000 each day now. To date, over 53,000 incoming passengers have received health screening. This achievement took the cooperation of nearly 200 commercial airlines, a like number of overseas airports, and the Civil Aviation Authority of China. The department is also working closely with our sister federal agencies under the task force. Their expertise and authorities were all necessary to accomplish this success. On January 31st, the administration declared that the virus presented a public health emergency in the United States. That same day, a presidential proclamation established the framework for our travel restrictions intended to protect the U.S. public from this communicable disease while allowing American nationals to travel safely home. The travel restrictions first applied to China. It has subsequently been extended to Iran, and airport passenger exit screening has been introduced in Italy and South Korea with the cooperation of their authorities. To focus the expertise of the medical professionals conducting screening, the Secretary of the Department of Homeland Security directed all flights inbound to the U.S. carrying persons who have recently been in China to arrive at one of 11 U.S. airports. Significant consideration, coordination, and analysis among the federal agencies occurred to select those appropriate airports. Prior to and following the presidential proclamation, DOT and interagency partners proactively communicated with air carriers and others in the aviation industry. DOT hosted multiple stakeholder calls with over 475 invited industry participants, representing a range of U.S. and foreign carriers, domestic airports, trade associations, unions, and other valued partners. As we plan for community transmission within the United States, DOT will be coordinating similar efforts with transit stakeholders as part of the whole of government plan, which includes the state and local public health agencies that are on the front line of mitigation efforts. One of the lessons we learned from SARS is that the public reconsiders travel in the face of a new communicable disease. COVID-19 is having that same impact on aviation today. Industry analysts estimate that the virus will reduce passenger numbers by some 4.7 to 6% worldwide. The industry is resilient and snaps back quickly. At the peak of SARS, U.S. travel halved. Within 2 months, it was back to normal. The federal government and state and local governments are executing their long-prepared emergency response plans. The President's Coronavirus Task Force was constructed to coordinate the whole of government effort to work through the virus. We will work through it, and we will come out on the other side. Thank you, and I look forward to your questions.
Thank you, Mr. Sabat. Admiral Redd.
Good afternoon, Chairman Cruz, ranking members Cantwell and Sinema, and distinguished members of the subcommittee. My name is Stephen Redd, and I am the Deputy Director for Public Health Service and Implementation Science. I'm also serving as a senior response official in CDC's 2019 novel coronavirus response. Thank you for the invitation to testify today on behalf of the U.S. Centers for Disease Control and Prevention on our efforts to protect the health and safety of Americans from this disease, COVID-19. Let me begin by acknowledging that this is a new virus and a new disease. New information and science continue to accumulate, and U.S. government decisions to respond to this epidemic will continue to be based on that evolving science. Our overriding goal is to protect America from the effects of the virus. We're working to slow its spread into the U.S. and to minimize the impact. The U.S. government's approach to COVID-19 is built on years and years of preparing and responding to infectious disease emergencies such as SARS, MERS, Ebola, and pandemic influenza. A key component of our work is to support state, local, tribal, and territorial public health departments. This system is the backbone of public health and also of our responses to public health emergencies. Up to now, more than 1,500 CDC staff have been involved in the response, both at headquarters in Atlanta and in the field. Over the past 2 months, federal, state, and local governments have mobilized to protect the American people. As we've heard globally, we have seen over 90,000 confirmed cases, and those have occurred in 85 international jurisdictions. As we've discussed, several countries are currently reporting sustained community spread. CDC, with our federal and local partners, have instituted multi-layered aggressive containment and mitigation measures to slow introduction and spread of the virus into the United States. These public health interventions include early case recognition and isolation, identifying and tracking contacts, and in some instances, implementing movement restrictions or quarantine. We've posted targeted travel warnings for several countries, and even for cruise ship travel in Asia, so Americans can stay informed on proper precautions to take when and if they travel abroad. Measures the U.S. government has taken include denying entry to the U.S. for certain travelers. This step has reduced the number of people coming into the United States from China by over 90%. We've also, as you've heard, we've also funneled travelers from highly affected countries to 11 airports where we've instituted screening procedures, and to date we've screened more than 50,000 travelers. As of noon today, CDC has reported 120 cases of COVID-19 from 13 states. We expect to continue to find more cases, and we expect these cases will be a mixture of travel-related cases, of cases related to contact, and community spread cases. It's likely that we'll see some communities more highly affected while others remain virus-free. I want to recognize that people are concerned about this situation, as are we. As always, our number one priority is the health and safety of the American people. We appreciate that Americans are taking this threat seriously and continuing to seek information about how to be prepared. While the immediate risk to the general American public is low today, the U.S. government is doing everything we can to keep it low. Risk varies by exposure, and some areas of the country are now experiencing community spread. I ask you as trusted leaders in your communities to help us with our mission to provide clear information to you and your constituents by urging people to get the facts from CDC about how to best protect themselves and their families. Thank you.
Thank you, Dr. Redd. Mr. Ferrara.
Good afternoon, Chairman Cruz, Ranking Member Sinema and Cantwell, and members of the subcommittee. Thank you for the opportunity to testify today on CBP's response to the coronavirus or COVID-19. U.S. Customs and Border Protection is an integral part of the U.S. government's response to the virus, as our men and women serve as the front line of defense at and between U.S. ports of entry, whether they be land, air, or sea. CBP has been working closely with the Department of Homeland Security, the Centers for Disease Control and Prevention, and other interagency partners since cases of the virus in China began to increase. CBP and its federal partners have taken decisive, proactive, and preemptive actions to mitigate the threat, minimize risk, and slow the spread of the virus. With limited exceptions, all foreign nationals who have traveled to China or Iran within 14 days are ineligible to enter the United States at this time. DHS, including CBP, continues to work very closely with our partners at the CDC to route all persons who have been in mainland China or Iran in the last 14 days to one of 11 designated ports of entry where the federal government has focused public health resources. All flights coming from mainland China are funneled to one of the 11 designated POEs. There are no flights from Iran. However, all passengers coming from Iran are also funneled to one of the 11 POEs. For passengers traveling to the United States by air, we also work in collaboration with the air carriers and forward partners to deny the boarding of individuals that would be found inadmissible upon their arrival to the United States. CBP continues to facilitate CDC's enhanced health screening of travelers entering the United States. These screening measures are critical part of the U.S. government strategy to slow the spread of the virus and protect the American people. All travelers who have been in mainland China and Iran within the past 14 days or who exhibit symptoms consistent with COVID-19 are sent to CDC staff or DHS Countering Weapons of Mass Destruction, CWMD, contract personnel for medical evaluation. Travelers identified by CBP officers during their primary inspection are referred to a secondary screening area. In the secondary screening area, DHS, CWMD, contract personnel take the following actions in support of CDC. They verify if the CDC enhanced screening is required, collect contact information for travelers requiring enhanced health screening, ask travelers about health status, for example, if they have a fever, cough, or difficulty breathing, and take and record the traveler's temperature. CWMD is currently supporting CDC's enhanced health screening efforts through agreements with state or local EMS, public health, and first responders in an overtime capacity. CWMD established this capacity in response to the Ebola virus threat. These actions ensured a trained, vetted, and badged workforce was ready to rapidly deploy to support the CDC. DHS was able to use this established capability to quickly address the threat of COVID-19. At and between all ports of entry, CBP officers and agents continue to remain alert and notify CDC and other public health officials when encountering travelers exhibiting signs of overt illness. Officers and agents are well-trained and use a combination of travel history records, questioning, observation, and self-declarations to identify those requiring additional health screening. CBP also closely works with the U.S. Coast Guard to ensure that ships and crews with nexus to China or Iran are appropriately identified and screened prior to coming into port. At CBP, our employees are our greatest asset. We are taking every precaution to keep our workforce safe, especially those who may regularly encounter potential disease carriers. All of the CBP's operational offices have a 30-day supply of personal protective equipment, or PPE, including gloves, masks, coveralls, and hand sanitizer. These are located locally across all field offices, sectors, and air branches. CBP continues to work with DHS and the interagency to monitor the global supply chain impacts and project critical PPE needs for the CBP workforce. On February 5th, 2020, CBP issued an updated job hazard analysis to all employees that outlines the current comprehensive PPE guidance, which includes guidance about wearing masks under the appropriate circumstances. CBP continues to share information with our workforce on an ongoing basis. We are committed to doing all that we can to keep our workforce safe as they work to ensure the safety of our nation. Thank you for the opportunity to appear today, and I look forward to your questions.
Thank you very much to each of the witnesses. Before I begin my questioning, I want to submit 3 letters for the record without objection. The first is a letter from Commissioner John Hellerstedt of the Texas Department of State Health Services that is sent to Secretary Azar of the U.S. Department of Health and Human Services and others. The second is that letter requested that the CDC submit a written rationale for releasing patients from quarantine at Lackland Air Force Base in Texas. The second letter is a response from Director Redfield of the CDC to Commissioner Hellerstedt outlining the procedures for discharging patients. And then the third letter is a letter that I sent along with Senators Cornyn and McSally to CBP regarding the possible spread of coronavirus across our border. And I want to start my questions with that third letter. Mr. Ferrara, would you please explain how the screening process at the border currently works and how people coming through the 29 land ports of entry in Texas are screened?
Thank you, sir. At all of our ports of entries, our officers and agents are trained to look for folks that may exhibit signs of illness. So that's something that happens every day of the week in our operations. With particular note of coronavirus, COVID-19, we have issued guidance to our officers to ask certain questions about travels, particularly if folks are coming from China. Now Iran is included in that. And we do a question, we check travel documentations and other information to try to see if, in fact, that person has traveled to those 2 areas. If they, in fact, have, if CDC is available at the area, we work directly with them. If not, we have our reach back and we use our public health officials, local public health officials that we have relationships with to come to the proper conclusion.
So does CBP plan to work with CDC medical staff in the future to heighten the level of screening performed at those points of entry?
We currently work now with CDC and we follow the guidance, the medical guidance that CDC provides. So that interaction is continually happening, sir. Dr.
Red, let me ask some specifics about what we know of this virus. right now, what is the overall case fatality ratio for COVID-19?
There's a number that I could give you, but I'd like to say that as more cases occur and we gain more experience, that number is likely to change. There's been a lot of question both about the detection of the numerator, the cases that have died, and also whether all of the cases that have infection with this disease have been identified. That's particularly true in China, where the case fatality rates have been, in general, a little bit higher than they've been seen in the rest of the world. So I would encourage us to look to answer that question, to look for cases that have been imported into other countries and they're spread, and there's really a cleaner set of information.
With the understanding that information is still growing and there's a great deal unknown, what is CDC's best estimate of the fatality rate?
It's probably somewhere between, today I would say somewhere between 0.5% and 1%. And just to give you a frame of reference, seasonal influenza is about 1 in 1,000. So all of those estimates are higher than seasonal influenza today.
Okay, now that number differs from the estimate from the World Health Organization. What explains
It does.
that
I think that number is probably includes information from China, where there's a question of whether all the less severe cases have been counted. I think this is something that, as more cases occur in China, we're likely to see that percentage decline. But I think it's really stay tuned. But as what we know now is it's substantially more severe than seasonal influenza.
How about how contagious is COVID-19, and in particular, what's the predicted R naught? And if you would explain what that means as well.
Sure. The way that we assess transmissibility is how many cases occur from one case, how many additional cases can be sort of the downstream cases. Seasonal influenza, usually somewhere between a little bit more than 1 and 1.5 new cases is generated from a single case. For the information that we have right now for the novel coronavirus, it's probably between 2 and 3 or 2.5 and 3.5. That number is largely based on the experience in China. The elements of that, sort of what determines what the R naught is, that number of new cases, it has to do with the virus. It has to do with susceptibility of people who might be exposed to the virus, and then it has to do with the context. So situations where there's a lot of crowding, you might expect to see a higher R naught than in a place that had less crowding. So I think this is a number also we're going to be following. I would say there's been a little bit less variability in that particular number than there has been in the mortality.
Now, reports are coming from China that have indicated the incubation period can be up to 24 days. That differs from, I understand it, the 14-day protocol for releasing patients from quarantine. Can you speak to the accuracy of that report?
That's one report, and I think that is a key question. What we're doing, I think that it's just going to be important to monitor that. We have not seen secondary cases after people have gone through that 14-day incubation period. I think our preliminary indication was that actually the incubation period of this virus was a little bit shorter than, on average, than MERS or SARS, two other coronaviruses that can cause severe disease in humans. So I think that this is something that provides some margin of safety between the average. I think it's something we're going to have to continue to follow, and we'll adjust as new information becomes available.
So, Dr. Redd, are there common sense and reasonable precautions that Americans at home should be taking now if you're concerned about your health and safety and your family's health and safety?
Absolutely. And I think this is an opportunity. I would, as I close my statement, if you can help us with this, that would be terrific. But there are really things that we do to prevent respiratory infections in general. Hand washing, covering coughs. If you're sick with a respiratory illness, stay home. That can be a hard thing to do. I think in this circumstance, it's even more important than it is on a usual basis. And lastly, it's really important for people to stay informed. that the information is changing so quickly that if you know something at the beginning of the week, it could be different at the end of the week. And I think particularly areas where the disease has been identified as something that has been changing quite rapidly.
Thank you. Senator Sinema.
Thank you, Mr. Chairman. My first question is to Mr. Farrar and to Acting Undersecretary Sabat. It's my understanding that it can be difficult for airlines to comply with passenger data requirements if travelers choose not to provide complete data, or in the case of booking through third-party sites. I'd like to ask unanimous consent to enter into the record a letter from Airlines for America that has been sent to the Department of Health and Human Services outlining some suggestions to overcome this gap by having the federal agencies set up a single online web form for all inbound international passengers. That would be by sea, land, or air. And Mr. Chairman, if there's no objection, I'd like to ask that that be entered into the record. A single online web form would allow the CDC to directly collect information from passengers and provide for a more complete, accurate, and timely collection of data. My question to you two gentlemen is, what discussions, if any, have there been between the Department of Transportation, U.S. Customs and Border Protection, and the CDC with the concerns these airlines have raised along with their proposed suggestions? From a public health perspective, would compliance be improved if all travelers were directed to some sort of single portal? And if so, what kind of funding or additional authority would be needed from Congress to create such a system rapidly?
Senator, thank you for the question, your interest in this area. Like you, I just want to tip my hat to those in the airline, the aviation industry, and the association that have really stepped forward to try to offer common sense solutions to this challenge that we have. As you mentioned, this is a real need that we have within the federal government. As travelers are coming to the United States, we want to be able to trace them, so that if it turns out that somebody who comes in is ill, we can reach back and find out who else they've been in contact with. Previously, the information that has been gathered that we can collect directly from the industry only has about 20-25% accuracy. In part, you've alluded to the fact that much of this information comes through travel agents, which are not directly affected by the information that's provided by the air carriers themselves. So we have been working, I would say, multiple times daily, communications among the agencies and also with the association, trying to work through the technological difficulties of getting to the ultimate goal of this rule that has been put out, which the carriers have said will take 6 to 12 months to fully comply with. And so we don't want to wait 6 to 12 months to get that data. So we have an interim system that the carriers have been kind enough to work with us right now, paperwork-based, on the travelers that are coming in. That works well, given the small number of passengers we have arriving right now. We're down to fewer than 1,000 a day, or coming in mostly from China. With that, the system we have now covers that, but it's not scalable as we add more, the concerns of adding more countries to the travel. So we think that the proposal that the carriers have put forward is definitely worth looking at. And the challenge that we're going to have is a technical one of how well we work it within the various IT databases of the federal government agencies.
We provide all the information that we have in our systems to CDC via the airlines. And as the Undersecretary mentioned, it's not complete for the CDC purposes. What we've done is a stopgap working with CWMD, the contractors. We're manually inputting those into CDC computers directly at those 11 airports. To the first part of your question, we have participated. It's an all-of-government effort to speak with the airline industry. And this data exchange is a constant conversation, not just for this particular issue. So there are a lot of the right people working in getting through, but there are some challenges.
If you'd like to respond as well.
I think that at the moment we're trying to make the system that we have work, but it is clear that we need a better system. Just as a small example of how we're working together, when the Customs and Border Protection people didn't have computers to enter the data, we were able to provide those from CDC so that we could facilitate that entry.
Yesterday, I had the opportunity to speak with Vice President Pence, and as I mentioned in my opening statement, followed up with a letter to him this morning. My understanding is that there's a web developer who has the technology available to develop an app similar to the mobile passport app, that could be done as quickly as 2 to 4 weeks. Of course, the technical challenge is how do we get that across all of our institutions and deploy it. But I believe that that provides a real opportunity for us to address this contact tracing issue in a matter of several weeks rather than 6 to 12 months. So that's something I hope that we can work together on and consider how to implement that quickly. Like the question that I asked earlier, the collaboration between the transportation industry and the government is incredibly important, but pharmaceutical manufacturers are also currently leading the way in developing both a vaccine and developing a plasma-based treatment. Companies like Johnson & Johnson, Gilead, Merck, Sanofi, and many others are providing their expertise in dealing with previous pandemics and collaborating through the Biomedical Advanced Research and Development Authority, as well as other public health entities. There's been conflicting information coming from different parts of the administration on the timeline for not just the development, but the implementation of a vaccine for ordinary Americans to access, and that is unacceptable. So my question for you, Dr. Redd, is the CDC engaged with these biomedical and pharmaceutical companies both in the development of a vaccine and in development of treatment of those experiencing the illness? When one has been approved for use for either vaccine or treatment, how will the CDC work with others to deploy it amongst our transportation, border, and health personnel who, of course, are at increased risk for exposure because of the roles in keeping the broader public safe?
Thank you, Senator. I appreciate the last part of your question because I think that's where I can speak most directly. The NIH and the Biomedical Advanced Research and Development Authority are the main parts of the department that are working on both the basic development and then the advanced development to get a product that could be approved. I think that the example of the work that we did in H1N1 influenza would be what I would foresee. It's going to be a while before we have a vaccine that meets those, a vaccine and probably a treatment as well. In H1N1, the government procured the vaccine, paid for its distribution, and that was essentially a government-run program quite similar and actually built on the Vaccines for Children's backbone. For a product that wasn't licensed at the time, we also, we didn't procure it, but we managed the distribution of a drug called peramivir, which is used to treat influenza. I would envision that kind of a system. I think right now the real first part of your question is really the key one, is to get a product that is safe and effective.
Thank you. Thank you, Mr. Chairman.
Thank you. And just to underscore Senator Sinema's first question, my understanding is that the airlines have offered to contract with a third-party vendor and to cover the costs themselves to stand up a website and or a secure mobile app that they believe could be stood up within 2 weeks to gather the information that, as I understand it, CDC is requesting. And I just want, do each of the three of you think that is a good idea?
Short answer, Senator, yes, it's a good idea. We welcome the fact that they've reached out, they've made this proposal. Our challenge at this end, and we're working this as hard and as fast as we can, is it technologically feasible to be implemented? That's the one challenge we have. If we can, that's a great solution that gets us from the temporary solution we're working with now and not having to wait 6 to 12 months for a permanent solution.
The way the system is devised right now, CDC receives the information from Customs and Border Protection. I think, however, that information, if it's of high quality and complete, would be great.
If it's technologically possible and it meets all the privacy rules and all of the different standards, security standards, I think it would be a great opportunity to look into, for sure.
Okay. Thank you. Senator Gardner.
Thank you, Mr. Chairman. Thank you all for your work on this, obviously very critical. I want to thank our public health officials in Colorado for the work that they have been doing, and the governor of Colorado for the work that he has been doing to make sure that we have a 50-state approach that protects our people, as I know you are fighting each and every day for. So thank you. What steps has the CDC taken to coordinate with foreign governments to verify that their screenings and public health protocols abide by U.S. standards, specifically with regard to travel from hotspots like South Korea and Italy?
So we're in very close contact, particularly with the State Department and Department of Defense in Korea. My understanding is that both Korea and Italy have instituted exit screening to identify persons who might be ill with the coronavirus. I think this is really an ongoing global effort. We're also working with the World Health Organization. Our work, there's sort of two parts to that. One is in places where we have staff, we're able to directly interface. That's true in Korea, not true in Italy, is true in China, not in Iran.
Does it make sense to provide, to test everyone who comes in from countries of higher concern, 100% testing?
I think the problem with that would be similar to the symptom screening, that a person could be incubating the disease, be negative with a test, and then later they develop symptoms or maybe not develop symptoms and actually have the virus.
Okay. When airlines or other transportation providers have questions regarding how to abide by the CDC, IFR, and best protect their passenger and employees' health and prevent potential further spread of COVID-19, does the CDC have a person, a single individual, prepared to serve as a point of contact for those questions?
What we've done, and this is part of the rulemaking process, is that rule is out for comment. There is a way to provide comments to that rule. We're examining those
But we have
comments.
no sort of expedited procedure to appoint one person who can answer these questions?
There actually are multiple people that are reviewing that. So I think we're probably getting...
Reviewing the rule or
reviewing
reviewing whether or not we can appoint one person to answer questions?
Well, reviewing the comments that are being submitted.
Okay, so right now, if United Airlines needed to call somebody, there is no one person point of contact?
There is not. There is a joint...
That's a problem.
Email address that it actually gets better coverage than a single person would provide. So that there is, I think in effect, there is a place that, it depends also on what the issue is. If it's about the interim final rule, that really needs to
So how long does this interim final rule take?
It really, I think there is, that interim final rule will be continued until the public health emergency is over or until there's resolution.
And that's in effect now, or we're waiting for public comment?
The rule is open for public comment now.
Okay, so when does it go into effect?
The interim final rule is, the part that makes it interim has gone into effect already. So that's this process of collecting data from
So you're able to
individual
operate
patients.
under this as it is. So thank
Correct.
you. Thank you. Has the CDC provided updated guidance to states on when to test for COVID-19 in light of community spread?
Yes, sir. In fact, when we were coming over here in the taxi, there was a news report that's been released, essentially giving broader discretion to clinicians caring for patients to get testing done rapidly. So that was put in effect today.
And do you have national or international standards that govern airline precautions, disinfection protocols, passenger coordination, should an airline employee test positive for COVID-19?
We have guidance. I think the rules about that, I might defer to my colleague about the standards. We do have guidance that's posted specifically for COVID-19 on aircraft equipment issues, but there are also international regulations, which I might turn to my colleague.
And Senator, are you asking about the standards that we have for how we disinfect the aircraft, or about health standards, PPE for the crews?
Both. I mean, how we make sure the airplane itself is safe and how we make sure the crew is safe as well.
Okay. So on the several different measures, because we made a conscious decision when we issued the 212F, the travel restrictions with China, not to take down all flights, that we still continue to have passenger flights taking Americans back from China. We also wanted to put into place vigorous crew health protocols for both the passenger and the cargo planes that are flying back. And those differ in terms of the requirements for whether they can leave the aircraft or airport facility, and their contact with other people, and the amount of everything from washing their hands to the types of protective gear that they wear. depending on whether or not they are China-based, in other words, they're living in China and flying out of China to the U.S., or they're coming from the U.S., staying briefly in China, and then turning around and coming back.
And let me just ask one more question because I'm out of time, and I think it follows up on what Senator Sinema had said. So we have no way right now to 100% or near 100% contact every passenger on a plane who may be flying with an individual who tests positive for coronavirus.
Half true. Okay, but before we put in these interim measures, our contact tracing was about 25%. With the interim measures we have in place now at the F-11 airports that Mr. Ferraro was referring to, right now, according to DHS, they're at 94 to 96% accuracy with that contact tracing information.
If I may, Mr. Chairman.
I'd like to actually amend my answer. The guidance for cleaning, we're expecting to be cleared today or very shortly. So we actually don't have guidance up today. So let me correct what I told you earlier.
Well, I hope that gets approved immediately. Thank you.
Thank you, Senator Gardner. And I'll note for the record that while after this hearing commenced, the news broke that we now have the 11th fatality in the United States from California, so the first that has occurred outside of Washington State. Senator Cantwell.
Thank you, Mr. Chairman. Reverend Red, I'd like to cover a couple of things. One, we're trying to do a supplemental to get more funds out to the states for public health. I think hopefully we'll vote on this before the end of this week, $7.8 billion. I think there's $11.5 million that would be a grant to Washington State for public health. Do you think some of that money could be used to better direct the public towards the testing regime? Right now, we're being very broad. We're saying, if you suspect something, yes, call these various entities. It's just, and then people are calling their doctors and they're saying, we don't have that, and you have to go over here, and then they call them and they're like, no. So can we use some of the dollars that you're going to get to be crisper about how to go about the testing? If you want a protocol that says you have to call your physician first, let's clearly state that. And then let's be clear about how many tests a day that we're able to do and how we create a system for that. Does that make sense?
It does make sense. I think that some of that money certainly will be used for communication activities, and I think that guidance, clarifying that guidance on who should be tested and can be tested will be an important part of that. It's also likely to change over time, as has already occurred.
That's why I think if you create this site and create accurate information for people, then you won't have the anxieties of people saying, I feel sick, I have this going on, and I can't get a test. And so we want to alleviate that. And so I hope that some of those dollars can be used for that. Another thing that I would hope that you would advocate for is, so Seattle Flu Study was a research institutions, everybody working collaboratively to study and analyze flu results. Obviously, you had to consent to be in that. That is how we caught the one student. He thought that the individual student thought they were sick with the flu, and then 4 days later, when we finally changed the protocol for who could get tested, they tested positive. So I think now the University of Washington has changed that so that it also covers COVID-19. Every city in America should be doing this. Everybody should have a flu COVID-19 IRB. That's a research analysis. And the reason why it's important is so that we can see this interplay between those who think they just have the flu, and so we can track the genetics of where this is going, because now we find that it's all related to the Washington 1 case. And this is finding out how community spread works. So can we also do that?
Yes, ma'am. Actually, we are, I believe today there will be the collection of specimens in several jurisdictions with additional jurisdictions through the week, with the plan to build out a system that would be much broader, really to all the reasons that you said in addition.
But every city in America could start this now. They'd have it in place, and then they have to get the agreement, and they have to get the information so they can just put flu information in this. So.
Yes, ma'am. I think using the flu system, this is really being built on flu surveillance to add novel coronavirus so that communities will know if the virus is in their community, yes, and would be able to have an estimate of If it's not there, what's the certainty that it isn't there?
I think it'll help us. I'm glad the University of Washington got this done. So now for the airplane, which our colleagues were just asking about, how long can the virus material last on a surface?
The virus can last hours to a day. That's been the estimate. It's similar to other coronaviruses.
Up to a whole day.
Yes, ma'am.
Up to a whole day. Okay. I've not heard that before, but I'm glad you're clarifying that.
Different surfaces have different.
We've heard we've heard the generalization before, and I think that's what is sometimes confusing. So up to a day. And so now what do we need to do for our airplanes, given that?
Well, that's going to be in the guidance that we hope is released very shortly of what, there's really the health side of that guidance, which will be released, and then the issue that we addressed in the earlier question.
Mr. Sabat, do you want to comment on this? I think people are concerned about the obvious individuals and being able to contact them, but then people want to understand, what is our plan? What is the Department of Transportation's plan to communicate if the virus can be alive on a surface for a whole day? What kind of precautions do we need to take on our air surfaces?
Thank you, Senator, for the question. This is a whole of government effort because the Department of Transportation's authorities, when you look at the safety side, are really limited to safety to flight, which is to say, as we are in consultation with CDC, with the other agencies, and especially I think OSHA and NIOSH, which developed these, what are the standards for individuals on the airplanes. Our statutory, our focus is to ensure that the mix of chemicals and other treatments do not actually harm the aircraft itself.
Are you saying you don't have the authority to set this standard?
I'm saying, yeah, so we're saying that health standard is by design not our authority because it's a health authority for individuals.
Whose authority is it? Is it CDC's or is it?
The information that we would have would be guidance. It wouldn't be, it wouldn't have statutory authority, is my understanding.
Yeah, so, and my understanding, and again, I'm not the medical person on this panel, but much of the authority runs with OSHA, which is not on the panel here, and we are in discussions with OSHA on developing these standards.
Okay, thank you for having the hearing, Mr. Chairman. I think this is something we need to tackle right away. We need to understand what we are saying to the flying public about what the airline should be doing, what we should be doing to create the best and most positive environment for air transportation to continue. We, as you said, Mr. Sabat, we're going to want air transportation, and we want it to be done. So let's get this protocol clearly established. Let's work together, get it established. Thank you, Mr. Chairman.
Thank you. And to underscore Senator Cantwell's point, if there are authorities that are needed to keep the flying public safe, let Congress know immediately, and we will create whatever authorities are needed because the priority needs to be public safety. Senator Lee.
Thank you, Mr. Chairman. Thanks to all of you for being here and for the insight that you've provided. As you know, Congress is preparing to consider supplemental funding to several agencies to respond to the coronavirus outbreak. 2 weeks ago, the Trump administration requested $1.25 billion in new funding from Congress for various response efforts. I'd like to ask each of you to just respond briefly to share how your agency would plan to use supplemental funding and also to respond to a related question regarding, assuming the administration's request reflected the needs of agencies to respond. If Congress gives you substantially more than what the administration asked for or what you asked for, do you have a plan to responsibly spend all of it, and what would that look like? We'll start with you, Mr. Ferrari, and then just go down.
Thank you, sir. Currently, based on the current threat and projected threat, CBP has what we need to do our job. Should things change, working with the interagency and that threat vector change, we would certainly inform on our resource needs.
But you've got what you need right now without a supplemental, is that what you mean?
Yes, sir.
Okay. Mr. Redd, Dr. Redd.
Yes, we would use the funds substantial amount of those funds would go to state and local health departments to do the work that is being done right now on identifying cases, testing those cases in their laboratories, identifying contacts. This is very labor-intensive work. So laboratory testing would be an element of that at the state and local level. Communication, surveillance, some of the things that we talked about with the effort to test specimens that are collected for other respiratory specimens. So there'd be a suite of activities that state and local governments would do. At the federal level, we would be able to use those funds for many of the same things, but laboratory support, surveillance work, communication, the things that we do in emergencies. So that I think we would not have a problem spending all the money.
Okay, and with regard to the part of the question dealing with the $1.25 billion, I assume that included whatever supplemental sum you thought you might need. So if we were to authorize more than that, tell me how that fits in.
Well, I think it might be better to see where we are with the bill that's going through. I think that there is a scalability to the amount, a smaller amount of money would last a shorter period of time, a larger amount would last a longer period.
Okay. Mr. Spot.
Thank you, Senator, for the question. Under the game plan, sort of emergency response planning, this whole of government effort is led by the health community, specifically the Secretary of HHS. So the vast majority of the money requested, and I believe the money that's under discussion right now by Congress, is for the CDC and the other health agencies. Much of that money, or some of that money, would flow through them to address some of the needs, such as Senator Cantwell mentioned, about what we're trying to do with health guidance and protocols for airlines, but that money is going through HHS. So at the moment, there is no money requested specifically for the Department of Transportation.
Okay, thank you. Dr. Redd, reports indicate that the South Korean government has been trying to get a handle on who's coming into the country by having air carriers try to assess passengers as they're boarding the planes going into Korea to figure out whether they are suffering from the virus prior to boarding. Have you provided any guidance to air carriers in the United States dealing with how we would assess this issue with inbound passengers?
So I'm not familiar with, if I'm understanding the question with South Korea, we have provided guidance for screening that would be in passengers coming to the United States, but if there's something else, if we are working on that, I'm not familiar with it. I think that the value of that screening, a lot of that work is to figure out, collect some of the information that we've been talking about. That's the way we've done it in the past, to collect contact information so that those individuals can be tracked. This is very laborious, and that's really the reason for this interim final rule, is to do more to automate that system.
To automate the system whereby you collect data on each passenger.
Correct.
With an eye toward hopefully excluding those who might bear symptoms or show some indication that they carry the virus?
Largely, we can screen for symptoms, but it's that question from earlier. If a person is incubating the disease, being able to track them through that incubation period is something that, or at least informing them that if they have symptoms, here's what you should do. So I think we wouldn't be able to identify people who are incubating disease from the contact information, but we could use that information to follow them.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you. Senator Schatz.
Thank you, Chairman Cruz. Thank you to all of the testifiers. Dr. Redd, I'm trying to get a handle on what our national strategy is in terms of containment versus mitigation. And it seems to me that containment is something you do in the first phase of something that's a potential pandemic, and that we are rapidly entering a phase of this during which there's sufficient community spread where the containment strategy has sort of vanishingly smaller and smaller returns. And I want to make sure I'm getting that right and then ask a follow-up question.
That is correct. I think one sort of nuance to that is that there are likely to be parts of the country where mitigation is the right posture, At the same time, there could be other parts of the country where,
You can still use containment.
right, exactly.
Okay, so my next question was, if we're into mostly a mitigation strategy phase, then why restrict air travel at all? In other words, if we're talking about restricting air travel from Korea, but it seems to me that with the exception of that episode and that religious organization in the southern part of South Korea, that what's actually happened in South Korea is they just tested more and got very aggressive about it. So their data is in, our data is not in. It's not clear to me that there's 6,000 or 7,000 cases, that their numerator and denominator is going to end up any higher than ours will end up by the time we do all of our testing. And so then it gets a little silly if we're not allowing people to travel when one place is not any less or more safe than the other.
So I think I agree with your general point. I could give the example of H1N1 influenza, where for a short period of time we had a travel advisory to Mexico. That didn't last very long because you'd be more likely to get H1N1 in the United States than you would if you were returning from Mexico. So that would be a situation where we wouldn't. That would basically be a scenario like that would be when it wouldn't make sense to do this really intensive effort to track people that are entering the country.
Okay, and just a new question. Your website right now says there are 80 total cases. That's not true, is it?
We update that on a daily basis, and as cases are reported from states, they do that on their own schedule. So ours is a kind of a once a day.
Right, but it's sort of garbage in, garbage out. We just don't know yet. It's not that it's 80, it's that you've confirmed 80.
That's correct.
Okay, so I would just recommend that you figure out a better way to reflect, and I understand the uncertainty here, but what's going to happen, I'm afraid, is that right now people are, I think, unreasonably reassured by this low total case count and unreasonably fearful of other places that are actually, really what's happened is they've deployed tests more efficiently and effectively than the United States has. And so what's going to happen is we're going to be calm until the tests get deployed, and then those numbers are going to spike like crazy, and we're going to have a panic as a result of that. So I think you've really got to figure out on the communication side how to reflect that uncertainty and prepare the public for the very high likelihood that the number of cases that we have confirmed is going to skyrocket, not because epidemiologically anything changed, but because we finally deployed the kits.
Yes, sir. I think we'll know the study that Senator Cantwell described to us will help address that issue. If we do more testing and we don't find, I think that is possible. I think that...
I'm talking about in the next couple of weeks as
right.
the testing goes right
exactly.
out.
No, I agree.
So final question for you. This is so constructive and so bipartisan. I thank the chairman for convening this hearing and the ranking member. Can you ask the folks at the CDC if they would commit to a daily briefing on camera, no politicians involved? It doesn't have to be inflammatory. It doesn't have to be alarmist, but just a daily, here's what's going on. Because that's what happens in a natural disaster context. That's what happens when you have a sort of a civil defense issue. We just need to hear from a singular, authoritative, informed voice and on a daily basis so that we're not all catch as catch can trying to figure out where the data is and where this thing is going. Mr. Zabat, am I pronouncing your name correctly?
Yes, Senator.
Oh, good. My understanding is the FAA has the authority to implement an emergency order so that those, as you were talking to Senator Cantwell about this, that right now there are guidelines, and then I understand that under normal circumstances, you're talking about whether or not the airplane can fly safely. But these are emergency circumstances, and I don't want to spend another 2 or 3 weeks figuring out whose authority is necessary to sort of, and get a bunch of lawyers involved trying to figure out where you derive the authority. In an emergency situation, you are certainly authorized to change those voluntary guidelines that the airlines, some are abiding by and some not, and just change that into an emergency order. And I'd like you to look at that, please.
Senator, we will, and we will look at it as a whole of government effort. One of the reasons for the task force is to say if there's something that has to be done and it legally falls through the cracks of the authority of one agency, we borrow the authority of other agencies in order to get it done.
Thank you.
And Dr. Redd, Senator Schatz asked about testing. From my conversation yesterday with Vice President Pence and Secretary Azar, my understanding is that testing kits are going out. What was told to me is by the end of next week, the capability will be there for 1.25 million tests. Is that accurate?
That is a combination of numbers from the public health tests that CDC is deploying that are done in public health departments and what could be done by private companies applying through the FDA process to use a test that would be a commercial test. But that number is in the range that I've heard as well. Very small portion of those would be the public health tests. The majority would be company developed.
So one of the great frustrations is a lack of testing. You're telling the subcommittee that the kits are on their way and testing, that will be remedied shortly. Is that correct?
For the public health testing, we will have the capacity to do 75,000 tests by the end of this week.
Okay. Senator Sullivan.
Thank you, Mr. Chairman, and thank you to the panelists for this very important briefing. Secretary Zabat, I want to follow up on our earlier phone call, my discussion with you today, and see if there's any more progress. You know, the broader discussion for the other witnesses is we've closed down the passenger travel from China and other areas where there's been a risk, big risk, on the issue of mitigation of the spread for air travel. However, there is a loophole, and I think everybody I've been raising this issue now for going on 4 weeks with senior administration officials. The loophole is cargo. Air travel, its cargo is very important for the whole country, for the whole world. We want to be able to have the supplies to address and be ready for, you know, what could be a significant challenge for our country. But the pilots on these cargo flights in some ways are a loophole. You have Chinese-based crews that get off in the United States, big cargo hubs, whether Anchorage or Seattle or LA, Memphis, and they spend the night, you know, and they're in the population. There's nobody I've spoken to, and I've spoken to everybody, including Secretary Chow and others, that doesn't recognize this loophole. But the agencies seem to be ping-ponging back and forth on how to address it. The one suggestion that I have made is to essentially do a turn and burn. You have cargo passenger airplanes come, say, to Anchorage. They have 2 sets of pilots. They land, they get rid of their cargo, and then they get the other pilots to fly it back. There was some concern they might retaliate against our cargo airlines. However, some of the senior officials I've spoken to don't seem to think that would be a problem. So can you, Mr. Secretary, I'm hoping you can have a little more definitive answer than our discussion this morning. Can you tell this committee what we're doing to address this issue? Because here's the real problem. If somehow there's a spread in another city, say Anchorage, and it's traced back to, a pilot on a cargo crew, the likelihood of us then wanting to react to shut down the whole system is going to be strong. So we're trying to preempt this with some good ideas. These are decent ideas. They're workable. Nobody's really complaining about them. But the authority seems to be ping-pong back and forth. What are we doing to address this overseas base crew loophole that everybody acknowledges we have?
Senator, thank you for the question, and thank you for the courtesy of flagging this for me earlier today. I regret I do not have a more definitive answer for you now than I had this morning, except to say we're working this hard. We'll have a definite answer to you as quickly as possible this week.
When will that be? I've been literally raising this for almost a month.
Okay, so
month.
Yeah, so today is Wednesday. We'll have it to you by close of business Friday, and hopefully before.
And will that be cleared by everybody? No ping-ponging in terms of FAA doesn't have authority. There is this issue that some people are viewing the crew rest doesn't count if you're sleeping on a plane. Again, we're kind of dealing with an emergency here. I'm sure the pilots who are resting on the plane as they're sleeping to come over are rested enough to fly it back, okay? They're all capable. I mean, and so again, if that's a reg or an authority that you need help on, let us know, but don't use that as, we're 4 weeks now since I've been raising this with people, and so far so good. We haven't had a spread from a cargo pilot, but I think we're dodging bullets here, and we need to address it.
I'll have a whole of government answer back to you by close of business Friday, Senator.
Thank you. Admiral, I want to ask and highlight another issue that's a little bit more particular to my state, the great state of Alaska, where one concern I have is our Alaska Native populations, where there's over 200 communities in my state that are not connected by roads. So they're very isolated in very, very remote parts of America, the most remote parts of the whole country. They don't have hospitals. They barely have clinics. Some of these communities don't even have flush toilets and clean water, which is a tragedy for the whole nation, in my view. But as you likely know, the 1918 Spanish influenza decimated these communities in Alaska, decimated them. So they're vulnerable, and what I'm concerned about is if there's enough focus from CDC, we do have a CDC office in Anchorage, in part because of our high rates of infectious diseases. What is the CDC doing to make sure that these extremely vulnerable populations, if you ever get an outbreak in one of them, we're ready to address these situations so we don't have a situation that happened 100 years ago, which was in some ways still an impact on my state?
Yes, sir. I think this is an important issue. I know that you know that Dr. Jay Butler, who had served as the state health officer in Alaska, is now in Atlanta at CDC.
Yeah, he's outstanding.
So I think we have that local knowledge of Alaska now in Atlanta, and I think that will help to make sure that we don't forget about a remote population. I think it's a real challenge, though.
Can I get your commitment to have something a little bit more definitive than that recognizes the vulnerabilities of certain communities like this that are very remote? Some ways you might not get, so the remoteness helps with the spread, but if it does get out there, and there's really there's no hospitals, there's very few doctors, can I get your commitment to have a more definitive plan to help address these kind of...
Let me commit to get back to you with what our proposal would be, and we can have a dialogue about that.
Great, and you might want to work with the CDC office in Anchorage, which also
Yes,
has coordination with our native health system. Thank you. Thank you, Mr. Chairman.
Thank you. Senator Tester.
Really? Doggone it, I appreciate that, Mr. Chairman. Now you'd beat me. I appreciate you all being here, and I want to thank you for the work that you've already done on this critically important issue. And I think it is critically important, and I hope it doesn't turn out anything like I have imagining potentially in my head. So I just want to give you my circumstance, and that is I fly 4 legs a week. I have town hall meetings. I meet with people all the time, probably meet with 70, 80 people today alone. The question is that if anybody's going to get this, it's going to be people serving the United States Senate, because we all do that. Senator Cruz flies home. He takes a different airline than I do, flies a different leg, exposed to a different population, then we come back and have a Commerce Committee hearing together, okay? So the question that I have for you is, I got the washing the hands and getting the flu vaccine. Is there anything we can do to protect ourselves? I don't care who answers it. That you would recommend, or do we just have to do what, and that is hope you don't have something else wrong with you, and so that you can get through it and survive it and move on?
So let me give a broad answer to that. I think hand washing is a critical element in protecting yourself, and for all of us protecting ourselves. There is kind of the other side of it, which is things that we want other people to do who might contract this disease and give it to us, and that would be covering coughs. Really, really important to stay home when sick, and I think that is probably something that we're going to have to just continue to stress. And that doesn't protect the person who's staying home, but it does protect everyone else. I think I hear all those things. So what is the incubation period on this stuff? Do you know? Well, on average, 5 to 6 days, with a range of shorter, a couple of days to maybe up to 2 weeks, as we've heard.
So I got a few achy bones today. I mean, I stay home.
I think I would not stay home or use that as a reason for coronavirus. I think fever and respiratory symptoms would be where,
So by the time you stay home, you've already been affected for 5 or 6 days, or what you're saying.
well, you've been incubating. I think this is one of the
Okay,
issues.
so do we know, and you can say, no, we don't know if we don't know, but during that incubation period, can I spread it to the good senator from Illinois?
So
did.
I don't think that you're going to like my answer.
I did wash my hands. Okay, go ahead.
It's not possible to give a definitive answer on that. I'd say that there is a much stronger suspicion that with very mild symptoms or right before you develop symptoms, that there is in a lot of cases the chance of spreading the disease, which is different from the other coronaviruses, different from most viruses where the viral load increases the sicker that you get. This may be a case where viral load can be high even in that very early, just almost like the symptoms that you described.
Yeah.
I wish it weren't true.
No, I got it. So how long do you think it's going to take for this to run its course in our population?
I don't think that it's possible to speculate. Really,
Nobody knows.
There are a lot of factors that could go into that, but so it really isn't possible to say.
Okay. So there's been a lot of talk. The good Senator Jackie Rosen just told me that Italy just shut down some of their schools. I think there's been talk about shutting this place down. There's talk about shutting all sorts of stuff down. I'm going to tell you, I personally think that's a mistake because I'm not sure it's going to matter, to be honest with you. And I think it a paralysis here is bad enough without really creating a paralysis. And so what would be your recommendations on all that stuff? Because it's like you've got a person with coronavirus at an airplane, so they come in and they clean the airplane, and somebody else gets on with the coronavirus. You really haven't done a damn thing.
So that's a very difficult question. I think it's one of the reasons that the president has set up the system that he has with the vice president in charge, that those different sectors are able to communicate more effectively so that we can talk about what the health benefits might be, but the adverse consequences, we're not really expert in those. So I think this is something that will facilitate the appropriate decisions being made as quickly as they're needed to be made.
Good. This is a question for Mr. Zabat. Do you believe that there are going to be flight restrictions placed if this thing plays out as potential?
Well, the easy answer to that, Senator, is we already have flight restrictions in place.
I know, but I'm talking about domestic flights.
I don't know. We're outside the playbook. You know, the original playbook did not envision travel restrictions. Health officials have historically said in the case of widespread flu or similar contagious diseases, we don't do travel restrictions. We went outside the playbook on this one, and I would contend that the travel restrictions that we and some other countries did were very effective. In some cases, they weren't. Italy, for example, did even more of a prohibition than we did, but they waited till after we did, and it did not turn out to be effective. So there's going to be a lot of lessons learned from that. But to your question, yeah, it's now in the playbook, something to think about. But I can't tell you under what circumstances we might consider pulling that trigger.
Okay. Well, I just want to thank you all for your good work. I can't thank you enough. I have been frustrated with the president and his reaction to all this from the get-go, but you guys are pros, and I want to thank you.
Senator Capito.
Thank you, Mr. Chairman. I thank the three gentlemen here today. I want to just ask just a general question of Mr. Zabat. Are you, and you may not have these statistics, but as of now, do you see domestic travel on the decline because of this, and people canceling flights, less people traveling? What are you all seeing?
Senator, thank you for the question, and you're better served asking that question from the industry and industry analysts who have specific numbers. But certainly from what we are in daily contact with the industry, and they are looking at a decline in bookings going forward. Having said that, so far the biggest hit for the airline industry has been on Asian travel, For the U.S. industry, that's the smallest part, both of their revenues and especially of their margins. This only becomes a major hit for the U.S. flagged airlines if the coronavirus spreads or concern of the virus spreads and passengers decide not to travel largely domestically and secondarily between the United States and Europe.
Thank you. Mr. Ferrara, thank you for your work at CBP. And we had the TSA administrator in front of my subcommittee, which is Homeland Security Appropriations, the other day. He was talking about the protocols that have been put in place that you all are coordinating with. Let me just say, when somebody comes in and is at the 11 airports, those are the citizens coming into the 11 airports, you do a pre-screening, you do that in coordination with CDC. What if somebody like exhibits the systems? Then are they tested immediately, or how is that rolling out?
Thank you, ma'am. As you said, once they come to one of the 11 airports, our officers identify them as potentially being ill or at least coming from either Iran or China. We refer them over to CDC or CWMD, who's there. That's a medical determination, so they would determine if a test is required or not. As our law enforcement, our priority is the law enforcement piece of it, making sure they get there. Yes, ma'am.
Get where they need to go.
Yes, ma'am.
It was brought to my attention that there was an article in the Wall Street Journal this morning, the title of which is "Hackers Target Companies with Coronavirus Scams." I mean, it's pretty shameful that people would try to capitalize on what we see as some growing fears and anxieties about what's going on. I don't know if this is a Homeland Security question. I know absolutely you all have cybersecurity capabilities within your agencies. Is this something that you all are made aware of, that there's people that are impersonating the World Health Organization? Obviously, this is a money-making kind of scam. Dr. Redd, do you know anything about this?
I was not familiar with that article. I think that the general issues of cybersecurity are ones that we need to take very seriously, and I think this would be an example of if those measures aren't in place, how that can lead to trouble.
Well, you can imagine a scenario of a hacker contacting somebody and saying, you want to buy 25 masks or some preventive or a vaccine or expedited travel or whatever you would be offering would really make a lot of the population very vulnerable to this kind of attack. So I would suggest that all of you in your respective departments take this back with you as a red flag. Mr. Ferrer, did you want to say something?
Yes, ma'am. That is a Department of Homeland Security. That's one of the
Right.
functions that we do have. So I will certainly bring that back and provide that information to the department.
Let me ask you too again on, we've talked a lot about aviation. We obviously know about the cruise ship situation that occurred. We also have a lot of cargo going back and forth all around the world, but certainly to the Far East and coming back in. I think initially, when I raised this question, Homeland Security said, well, the incubation period is so much so that if you're on a ship for 14 days getting back and forth, it's really not going to be an issue. But we see that it really is an issue because it could be passed from time to time to time. So are you working with the Coast Guard on this to make sure that wherever those ships are coming in from, that you have some kind of capabilities there?
Yes, ma'am. In conjunction with the Coast Guard, we, again, target people from either China or Iran who are traveling on those cargo ships, and we make sure, working with our medical partners, to keep those folks out of the port until we get the all clear from the medical folks.
Just as a regular course of everyday living, today I kind of challenged myself to try to see how many things I could not touch that I know had been touched by numerous people before me. What a challenge. And so I think if everybody would try the exercise around the country, you would realize how not just susceptible you are, but how careful you need to be when you know you've been in some kind of contact or direct contact, or you yourself maybe have a cold or are beginning to not feel well. So that was pretty staggering, starting with the elevator, the doors, the restroom. I mean, we could go on and on. Constituents coming to visit and all those things. Thank you very much, Mr. Chairman.
Thank you. Senator Duckworth.
Thank you, Mr. Chairman. I want to thank you and the ranking member for having this hearing. As of yesterday, Illinois, my home state, has had 4 individuals test positive. I wish them and everyone else who has been infected a speedy recovery, and I want to credit all of the staff at the state and local levels for the work that they've done. But I have to share my frustration here because I can't believe that we're having some of the conversations we're having now after having faced other global outbreaks such as H1N1 and SARS. Did we not learn anything about processes and procedures from those previous diseases? Americans have been flying commercially for more than a century, yet today, on the cusp of a global pandemic, the inability of the federal agencies to collect and share critical data effectively with U.S. airlines and state and local partners is really hindering our ability to stop the spread and to fight this disease. And so, my last job in the Army when I was finishing out my last tour was working at the Pentagon in the DISC Ops, which is the Defense Support of Civilian Authorities. And the last thing I did was give a briefing on global pandemics and what we would do in our particular office. Dr. Ray, you worked on H1N1, right? You alluded to it earlier.
Yes, ma'am.
Okay. That was in 2009. So how the heck has the CDC, the CBP, and DOT, how come we are still trying to figure out how to deal with these issues? How is it that our CBP don't have computers? How come we don't have a way that we're talking to airlines? How did we get here after we've seen Ebola, we've seen H1N1, we've seen SARS, and what are we going to do in this instance, but then also looking forward so that the next pandemic that hits, and there'll be another one, that we're ready for it and we're not caught flat-footed the way we are right now?
I think that we have improved since really my own history begins with the mid-2000s, and I think we're far ahead of where we were at that point in time through a lot of hard work and attention from the members here, Congress and the administration. I think that you're pointing out some things that need to change, and I think that there will be both in the very near term work to make sure that we're operating as effectively as we can now, and that there will be after action review items that will come out, many of which you're listing.
So how long, for yourself and for Mr. Ferreira, given the data sharing challenges with airlines, how long does it take for state emergency management agencies and public health departments to receive flight information about potentially infected travelers? How long does it take a State Department? I mean, I have one of the busiest airports in the world in Chicago. How long does it take IDPH, Illinois Department of Public Health, or the local officials to receive information about a flight that's coming that potentially has an infected patient on board?
Yeah, CBP transmits the information from these flights within an hour over to CDC. I don't know the process from CDC to the states,
Okay.
but the information that we do have, we transmit within an hour.
Okay, Dr. Red, how long does it take before my IDPH gets
Well,
it?
I think the problem is that the information is often incomplete, and that is really what the interim final rule is trying to correct, is that if we have a name, that's not very helpful. If we have a name and an address, that's somewhat helpful. If we have a name, address, phone number, email address, we can find people. And that information at the health department, there'll basically be the ability to do complete follow-up if those data elements are available.
So you don't have a time frame for me right now, and we don't know when we're going to have the capability to rapidly let local public health people know.
Well, I think for what we have, it's a very short period of time, but the real question is getting complete information and doing that in a timely fashion.
And Senator, if I may just add to that, because this has been discussed at the task force level, the goal of CDC, the health officials, has been to collect the information so that CDC has it by the time the plane arrives and is already providing it to the local officials. The challenge that we have to the public health officials to where those passengers are actually going, because of course they come to one of 11 airports for initial screening, but that's not where they're ending up. So if someone's flying into Chicago who's going on to Massachusetts, CDC wants to gather the information and extend it to the public health officials for wherever in Massachusetts they're going to. And the system that we have right now is an interim system which is working very well, but it is paperwork and personnel intensive, and so it works for the passenger load we have coming in now from China. We could not scale it up to be more broad, and that's the challenge we're talking about having a better nationwide system. Having said that, the system we have now is immeasurably better than anything we've had before, whether it was with H1N1 or with SARS. So each time we have one of these, we learn. And as Dr. Red said, we'll do a hot wash after this. We will learn from what we've done here, and we'll do better next time.
Well, I think we need to do a lot more than better next time, and I would ask the chairman to maybe consider holding a hearing after the epidemic and see and learn about lessons learned and what they plan on doing next time. I do want to add one more loophole to what my good friend, the senator from Alaska, mentioned with the cargo. Dr. Sabat or Dr. Red, are passengers aboard charter and private flights from areas of concern receiving the same scrutiny as passengers aboard commercial flights? Because I think in addition to the cargo aircraft, private aircraft are another loophole that's in the system. And I'm out of time.
Please answer that question. It's a good question.
So I'll answer the question. Senator, we'll get back to you with a full answer for the record, but I know I can speak personally. For example, for charter aircraft, we apply exactly the same rules to them as we do to any commercial aircraft. So if you're coming, for example, from China or now from Iran, well, we don't have direct flights from Iran, but if you're coming from China, you would have to land at one of the F-111 airports.
But what about private?
And I'll get you an answer for the record on that.
Okay. Thank you, Mr. Chairman.
Thank you. Senator Rosen.
Thank you, Mr. Chairman, for having this very important hearing. Thank you for the work that you're doing. I know your staff, you're just working around the clock to try to figure out how to get ahead of this, be proactive, protect our nation. So I just want to share my appreciation in that of all Nevadans with you. But since the coronavirus is changing so rapidly, it is critical that our public health officials doing the work on the ground, as Senator Duckworth says, have all the information they need to do contact tracing and the monitoring of travelers when warranted. So I'd just like to understand what the threshold metric being used to determine when air travelers must fill out that government public health locator form. Can you explain that to us? Are people not having to do that? What is the threshold? Are it just people from China, just people from Italy?
Okay.
Please explain that.
The way for the current rule, it is travelers. The interim final rule applies to travelers from China
Only. So we're not doing it for anybody outside of China. So should we expand that?
With your permission, Senator, I'll take that on. We have two countries now that are covered by the so-called 212F process, which has this, which are travelers from China, travelers from Iran. We have no direct flights from Iran. Very few Americans will be coming back from Iran in a 14-day window. So for the most part, the IFR rules apply to those travelers. But we're looking at a model that can be scalable and expandable. So, for example, right now we just introduced new types of restrictions for travelers coming from Italy and South Korea, where they're getting exit screening coming out for those countries. But they're not being required to do the same kind of data collection that we're doing right now.
Who's doing the exit screening? What qualifications and training are you providing for that?
Okay, so it's a careful answer to that question, Senator. These exit screens are being done by the authorities in South Korea and in Italy. So we don't
before they come.
Exactly.
Here.
Exiting from there when they come here. That's correct.
Okay. So you're thinking about expanding it, and you'll obviously keep us apprised of that and considerations for that. I also want to build upon that a little bit because obviously we're talking about air travel, and we have all of our wonderful flight crew, the pilots, the attendants, people who clean the cabins, but really the flight crew health, given the direct interaction and contact that the flight crew has with hundreds of passengers. I'd like to hear a little bit more about the recommendations for ensuring that their health is protected, and what requirements does the DOT have for personal protective gear for flight staff, such as masks and gloves, if those become recommended by public health officials.
So I'm going to start with the answering this question, Senator, and I'll put Dr. Red on notice that it'll get passed on to him. Department of Transportation, we of course work closely with the industry, and we hear from both the representatives of the pilots and the flight attendants. But our role on the PPE side is that we pass on either the guidance or the requirements and it can be OSHA, NEOSH, or other health agencies. So we are in a sense, from the Department of Transportation perspective, we're a pass-through Given my position on the task force, the role of the task force is to ensure that that guidance is put out. And if I may just put a plug in, because as you point out, we give a lot of praise often for first responders, but first responders are responding to something. Our flight crews right now are on the cutting edge. They are ones right now dealing with these risks every day, and we do owe it to them to make sure that they have the very best equipment and the very best knowledge of how to perform self-safety practices.
Well, and so you talked about you're the pass-through. So how are we going to compel the airline industry to be sure that the health of these workers are protected as they look? We all of us fly every week, multiple legs on many different airlines for a living.
Right. So at the moment, the requirements that we have are the airlines agreed to meet these voluntary standards. Now, if they refuse to meet them or fail to meet them, we can consider other measures. But right now, it's clearly in the economic interest of the airlines and certainly in the personal interests of their pilots and crew to follow these measures.
And I just have a quick second, so I'm going to make this very short. Are we providing, or are you helping the airlines to provide training, additional training to those flight crews for looking for signs of illness so that they may help when people are on the plane or when they're getting off the ground and assisting in any of those reporting issues there?
There's a lot of interaction with the airline industry in that domain. I'm not familiar if we're actually doing something very specific to coronavirus, but there's been a long-standing collaboration in that kind of work. But let me follow up specifically on that question. We do have guidance for protecting crews. Again, it's this question of voluntary guidance and kind of what you should do versus having the rule or the authority to do that, which resides with OSHA.
Well, it's not just a question of the flight crew's health, but then they become carriers in and of themselves. And so that's the spread, the public spread can be great. So thank you, I appreciate it. My time is up.
Thank you. Senator Thune.
Thank you, Mr. Chairman. Thanks for this hearing, and thank you to all of you for everything that you're doing, continue to do to address the crisis. And Dr. Redd, first of all, I want to I appreciate the CDC's work in containing the spread of coronavirus, and I want to thank you especially for being here today. And I want to just follow up on some questions I think that have already been asked. But my understanding is that CDC has issued guidance to air carriers to ensure that they're taking the precautions necessary to contain or respond to potential coronavirus cases on international flights. So the public is aware. Could you just kind of, again, perhaps talk about some of what those steps are, what the airlines are following?
I think the main thing is identifying patients who have respiratory illness and taking action to really notify. There's a system of communicating with ground if something like that were to occur, and it's really, I think, the standard guidance, but just putting a little sharper edge on it because of the situation that we're in with the novel coronavirus.
Do you, are there instances of domestic community spread that you've seen so far? And does the CDC anticipate the need to provide similar guidance to air carriers for domestic flights, that some of what you've done with international?
So there are locations in the country which have cases that have been acquired within the United States, specifically in Washington State and in California. And I think it would not be surprising that other locations would see cases like that. The guidance for identifying people who are ill is not limited to international carriers, so it wouldn't be only international carriers get that kind of guidance.
Mr. Chabot, I understand and agree with the current focus on major international airports and large cities and efforts to contain coronavirus, but it is important to ensure that smaller airports and public health authorities in rural areas are also prepared when confronted with a potential case. Has the department conducted outreach or provided guidance to smaller airports on containing the spread of the coronavirus?
Senator, thank you for the question and for the concern. We share the concern for the health of the entire traveling public, and of which smaller airports are an important part of that web within the United States. So we're working through, again, what I call the whole of government effort. When it comes to delivering health preventive measures to these airports, to any one of our private sector stakeholders, within the playbook, the emergency response planning, that falls under Health and Human Services and in Homeland Security. So our job is to ensure that those communications channels are open and are flowing. We have had, just in the last 2 weeks, 2 major conference calls, including aviation organizations and individual airports, for exactly this reason, to connect them with their first line is their own public health authorities, and then through that is the CDC for health guidance.
Yeah. Dr. Redd, what resources is the CDC providing airports across the country, including smaller airports, to ensure that they can properly respond to a potential outbreak?
I think in general, the quickest line of where to get help would be the local health department. We are certainly available to communicate, but we would have guidance and we would work that through the local, state and local health departments. So that's going to be the kind of the first line of defense in the public health system would be the local health department and the state health departments.
Okay. Mr. Ferrara, it's my understanding that CBP has enhanced screening measures at major airports across the country to increase the chances that infected passengers are quarantined or denied entry into the United States. Could you elaborate on the information that CBP collects on each passenger entering the United States during normal operations and how that has changed for points of entry where screening has been enhanced?
Thank you, sir. The information that we're collecting for contact tracing, it comes through the traditional CBP airline systems, and that's passed on to CDC. I think that's the only difference with the process is that it's passed on to CDC as a rule if these folks are coming in from those countries of Iran and China.
Mr. Shabat, does the department have an initial estimate for coronavirus's effect on global air travel to and from the U.S.?
Senator, the department does not, however, we're closely following what the industry analysts are saying. And so currently the current projection seems to be in the range of 4.7 to 6% decline in global travel over the course of the year.
And does the department believe that the reduction in international travel will potentially lead to supply chain constraints for certain medical supplies?
The department, as a department, does not have a position on that, but I can certainly say as a member of the task force, we see that there are disruptions in certain parts of the supply chain. We would take as a lesson learned going forward, and this is both true for our private sector counterparts as well as ourselves. I think there's a lot of lessons to be drawn here about having over-reliance on a single source of supplies.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you. Senator Markey.
Thank you, Mr. Chairman. Admiral Redd, good to see you, sir. Thank you for your service. My wife is a retired Rear Admiral in the Public Health Service, so I know your core, your work, and what you're dedicated to. So if you could, perhaps discreetly, just describe to us what it means when the president starts to call the coronavirus a hoax or puts out information which is medically inaccurate. What, from your perspective, is necessary in order for you to be able to do your job and for the public to be able to respond to the message which you're sending, which is medically accurate in terms of the disease itself and then what the response should be from the public?
I think that in the last several weeks, there's been a focus on making sure that we are in alignment as a whole of government approach. I think that that's been very helpful with Vice President Pence in charge. I think that will help make sure that when a decision needs to be made, that there will be communication across departments so that all the experts are able to work more closely together. I think that's going to be very helpful as we move forward here.
Okay. Well, thank you, but just know that we respect you and we respect science, we respect your conclusions, and we really don't want this to be politicized at all. That will interfere with our ability to implement a plan that is effective as soon as possible. I think we've already seen too much delay in not responding correctly and doing so soon. I'd like to come To you, Mr. Zabat. That's on the question of airline fees. We have a pandemic which is going to hit the United States in much larger measure over the next weeks and months, according to the experts. We have airlines that actually have taken charge fees, change fees, and they made a whole industry out of it in terms of the amount of money which they can, in fact, charge. The DOT is the only consumer protection agency overseeing air travel, and you are statutorily charged to stop unfair practices in aviation, allowing any airline to charge these excessive fees during the coronavirus outbreak is beyond unfair. So I urge the Department of Transportation to take action immediately and prohibit all cancellation and charge fees during this emergency. Anything less is a failure to fulfill your duty, and that's why I plan to send a letter to Secretary Chow later this afternoon, formally asking her to suspend these change and cancellation fees in the face of this public health crisis. The time for DOT to act is now. We don't want citizens deciding they have to fly, just because the cancellation fee would be too large if, in fact, from their perspective, given their own health, or their other family members' health, that it might be a danger to them if they came into contact. Would you commit to ensuring that the DOT, which is the Consumer Protection Agency, ensures that change and cancellation fees are suspended during this crisis?
Your concern and your request is noted, Senator, and you have my commitment that we will get on that right away. As you say, this is an emergency response situation. We're not looking to spend months or years developing a rule, so we'll get you an answer back very quickly.
Yeah, I think that's not an incidental issue for many families. I can see more and more people have flown like 7 times in the last 10 days. More and more people on each flight have a mask on. So for every one of those people, there's somebody else that's very concerned and didn't want to cancel the flight because they had to travel, but they might have if they didn't have the additional fee.
You're not the only one who's noticed that. I've noticed that several of the carriers in the industry have already decided to say that, that they're going to be that they will withdraw some of those fees.
Yeah, well, I just recommend to you that it become an industry-wide practice through your insistence upon it. I think it'll be great. And if I may, Admiral, the highest fatalities from the coronavirus have been in areas where the healthcare system has been overwhelmed. CDC must take steps to prepare hospitals for surges of coronavirus cases that could stress healthcare systems' capacity to care for those patients, especially those who may need hospitalization in airborne infection isolation rooms. CDC's current guidance, which hasn't been updated since February 11th, nearly a month ago, is for facilities lacking airborne infection isolation rooms to transfer patients to facilities with available rooms. But we know this option may not be available if there is a surge of cases in a particular region. Dr. Redd, can you commit to provide hospitals and other healthcare providers clear and specific guidance on how to safely care for a surge of patients without airborne infection isolation rooms?
Let me look into that and get back with you. I think that you're bringing up a very important point, and that if there are the number of patients exceeds the number of beds, there's going to have to be guidance for that situation.
Yeah. So you will provide clear guidance to those hospitals?
Yes, sir. Let me get back to you with that, but yes, we will do that.
Yeah, I think you will get back to me, or
yes.
You will provide the guidance?
First get back to you, and then provide the guidance.
I think they need guidance. I think that many places in this country need it right now. They need to know what to do. So I would honestly, I'd put a crash team together, try to figure it out tonight, put them in a room and send it out to these hospitals. They're out there waiting for you, you're the expert, to tell them what their plan should be. So I honestly believe that it could hit a region within the next couple of days and they'd be without any real instruction. And I think that would be providing a disservice to those people. So thank you, Mr. Chairman.
Thank you, Senator Markey. I think it is important to correct the record that I do not believe it is accurate that the President has said the coronavirus is a hoax. And in fact, I think that's quite contrary to what he has in fact said and in fact done. The President can obviously speak for himself, but my understanding is what the President referred to as a hoax was the partisan claim that some are advancing for partisan advantage, that the administration is not treating this public health crisis seriously and is not marshaling the resources to keep Americans safe. And I will say in my observation, having yesterday met with the Vice President of the United States, with the Secretary of HHS, with the Commissioner of the FDA, that the resources, with the head of the CDC, that the resources being marshaled are significant. And Admiral Redd, I want to ask you, in your opinion as a health professional and as a lifelong expert in communicable diseases, how significant was the step that the President and the administration took early on to halt air travel in and out of China and to quarantine Americans returning to China? How significant was that?
I think it was a very important decision to make, and I think that there was a prolonged period of time when we had a very small number of cases. So I think that was the right decision at the right time. I think that we'll be in a better position to evaluate that more fully as time goes on, but at the present time, it was an important decision.
In your medical judgment, had travel proceeded unimpeded, would we be facing, in all likelihood, a substantially worse outbreak in the United States?
We would have more cases, I think we can say for sure, if those measures had not been put in place.
And Mr. Sabat, from a perspective of the Department of Transportation, how unusual is it for an administration to take the steps this administration took right at the outset of this outbreak?
Senator, those steps were beyond unusual. They were unprecedented.
I can tell you I spoke personally with the President, I think 2 days after air travel was halted to China, and the President asked me directly, said, "Ted, what do you think?" I told him, "Mr. President, you made exactly the right decision. I recognize there are real economic consequences to halting air travel, but at the end of the day, the first priority has to be protecting health and safety, has to be protecting lives until we understand the scope of this outbreak, until we understand what is happening with this virus. We need to do everything that is possible to prevent this outbreak from becoming a pandemic." And so I am grateful that the administration acted. That doesn't mean every step the administration has taken has been exactly right. Dealing with any crisis, there are going to be challenges, there are going to be mistakes. But I think we have seen a serious focus on this public health crisis, and that's the right thing. And I would note one of the mistakes was releasing an individual from Lackland who subsequently tested positive, and that's a mistake that I addressed at the beginning of this hearing. I want to ask a couple more questions, then we're going to wrap up shortly. It has been reported, my understanding is that the CDC has asked commercial airlines in affected regions to take the temperature of passengers boarding planes, and that commercial airline gate agents are understandably feeling not prepared to do so, not trained to do so. They're not medical professionals. Is that understanding correct, and is it right to be asking the gate agent to be taking someone's temperature rather than a medical professional with the training to do that?
I will have to check on that. I'm not familiar with that process. I know that in Korea and in Italy, the governments are doing the exit screening. But let me get back to you on confirming that my lack of knowing about that is that it's not happening.
Mr. Sabat.
And just an update, because our information flow among the agencies here is good, but it's not immediate. So from the task force level, we've learned while these measures have been put in place by the respective governments of Italy and Korea, in consultation with our agencies, they've chosen how to implement it. So, for example, in Korea, there are 3 levels of screening, thermal temperature screening. 2 of them are walk-through. You walk past devices, one as you enter the airport, one as you go through security. But the third is they are asking all airlines, both Korean and U.S. that are flying to the U.S., to use one of those handheld temperature devices to check the temperatures of people who are going into the United States. So yes, so that is a request that the governments have made of the U.S. carriers as well as the foreign carriers to do that testing.
So is it your testimony, just so I can understand, that it's the government of Korea that is asking them to do it, not the U.S. government?
So the U.S. government is saying to the government of Korea, if we want to continue to have flights from the Korea to the United States, you have to do health screening. Come back and tell us, how do you intend to do it? And this is how they've come back and told us they intend to do it.
Well, let me suggest, and listen, I think health screening makes an awful lot of sense from everything I've heard, but the concern from airline gate agents that they are not trained and they don't have the background to be doing that screening, that seems a very reasonable concern, and it seems to me it ought to be health professionals that are doing public health screening. Let me shift to another issue on the CDC. Last month, the CDC received reports that some of the testing kits were faulty and experienced inaccuracies in their testing. Were there cases in which the CDC released patients after they had been tested with faulty kits, and if so, in what circumstances?
Let me go through the details of the Lackland case, and I think that is one instance where that occurred. And that was not, it was not a faulty test. It was a process of communication. Actually, the thing that you talked about in your opening statement is what happened. There was an individual who was ill, who had recovered from that illness, and the protocol at that point, and it still is the case, is that 2 specimens that are negative more than 24 hours apart is a requirement to release an individual. This person had 1 test that was negative, had a 2nd test that was indeterminate, and then had a 3rd specimen obtained that was negative, but that knowledge of that negative test didn't occur until after, let me get the sequence right. So that there was a negative test. There was unknown to the people that did the 3rd test. A 4th test was obtained by a different group. According to the protocol, there was the negative test, the indeterminate test, and a negative test, so that met the criteria. Unfortunately, that 4th test that wasn't known by the people making the decision to release the person turned out to be a positive test. I think so I think the real issue was the communication there, and no one should be released with a pending test. That's one just obvious thing that is really about the internal communication. I think that the meaning of that test and whether there was some issue with the test or with a person having a very low level of virus, I think that's something that we don't know right now. I don't think it was related to the other issue of the quality control work that was done on the original test.
Is CDC examining why someone who tested positive had 2 negative tests? That certainly raises questions.
Yes, sir. Yes, sir. I think one of the questions will be, I mean, this is really, it's a new infection, it's a new virus, and for example, in the Ebola response in West Africa, the role of sexual transmission wasn't something that was recognized before an outbreak of that size occurred. During that outbreak, it was learned that that can be an important cause of recrudescent really outbreaks or infections. I'm not suggesting that that's the case here, but just there's more that the scientific community is going to learn about this disease. I think it may shed some light on how an outcome like that could occur.
Is the current protocol for releasing someone from quarantine 3 consecutive negative tests with no intervening tests?
It's 2 negative tests separated by more than 24 hours, so that has not changed. I think that your suggestion that this is something that really needs a hard examination is completely correct. I think the real issue here was that there was a test that was out there that wasn't, the existence of that test pending should have been something that would have kept the person from being released at the first place. And then with the positive test, we wouldn't have had it would still be the question of how do you get that kind of sequence, but we wouldn't have had the situation where a person with a positive test was released.
So with respect, Dr. Redd, I think it's important to frame the problem. The problem wasn't that the 4th test had happened. We're grateful that it did because it actually caught someone who was still positive. The concern is why, assuming someone who started out as positive and ended up as positive, why were there 2 tests in the middle that were negative, and why was there an inconclusive test? Like that raises real questions about the accuracy of the testing, and I understand this is not an easy thing to do, but
I can give you some possibilities, but I think that I can't tell you for sure why that circumstance occurred.
Would welcome those possibilities.
One would be that there were a small amount of viral particles existing at that fourth test that were detected. It was a correct test, but the other negatives were also true. So we were right at the limit of detection that there wasn't actually live virus available, just kind of the remnants of that the nucleic acid of the virus still existed, even though there wasn't a live virus, and it was there in low amounts. So that, I think that would be one explanation. Another would be that, and I think this is kind of getting progressively less likely, but that there was some source of that virus that emerged, it's similar to the AIDS or the Ebola virus, where a person can test negative over a long period of time but still have the virus in semen. So maybe there's some protected site that we don't know about. I don't think that's very likely, but I do think it's a question that really demands scientific scrutiny.
Let me also raise another question about the protocols. So in the letter from CDC Director Robert Redfield to Commissioner John Hellerstedt of the Texas Department of State Health Services, Director Redfield stated that the 11 individuals who had been passengers aboard the Diamond Princess, that 11 individuals had been offered voluntary testing for the coronavirus and were asymptomatic for the entirety of the 14-day quarantine period. Is the reason the testing was only voluntary because they were asymptomatic? And does that make sense for lifting a quarantine if we know someone has been in an environment where they've been exposed?
I think this is a balance of individual liberty and protecting the health of the public, and I think that the experience has been that staying asymptomatic for that period of time, that those people would not have had a positive test. But I think it really is kind of the civil liberties versus protecting the public balance.
So are the current protocols that someone will be released from quarantine if they're asymptomatic for 14 days, whether or not they've been tested?
That's correct.
And those are the protocols, even though we had this exchange in our first Q&A.
Let me check back with you. Let me verify that before I say something that's incorrect.
I mean, there is that study from China indicating a 24-day incubation period. That may not be accurate, but if our current protocol is to release someone after 14 days without testing them, if there is an incubation period longer than 14 days, that could presumably contribute to the spread of the virus. Is that right?
If those two circumstances were true, yes, it would.
I want to thank all of the witnesses for your testimony, and I want to echo, you've heard senators from both sides of the aisle thank the professionals. I know you guys are not getting a lot of sleep right now. You are working hard, and this is a serious challenge. This is not easy. There are a lot of unknowns, and I believe we need to follow the science, we need to follow the medicine, but we need to also be proactive protecting the American public. And so I thank each of you for doing so. I also want to underscore a point that was made from multiple senators, which is if there are legal authorities that any of your agencies need right now to protect public health and safety and prevent the spread of this virus, tell us, and tell us quickly. I think you will find a bipartisan eagerness to ensure we have the tools to prevent this outbreak from growing, to prevent further deaths. But we cannot address legal impediments if your agencies don't draw them specifically to our attention. I would note we have a funding bill that is moving rapidly, and it is possible even as quickly as that funding bill attaching a provision to that if it proved necessary to addressing this challenge. With that, I want to thank all of the witnesses for their testimony. The hearing record will remain open for 2 weeks. During that time, senators are asked to submit any questions for the record, and upon receipt, the witnesses are requested to submit their written answers to the committee as soon as possible. And with that, this hearing is now adjourned.